What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. All right, everyone, this is part one, Beyond the Bite, Airway, Jaws, and Interdisciplinary Care with Dr. Duane Grummons. I'm Dr. Jenny Hobson. This is the Breathing Lab, and we are really excited to continue the conversation with Dr. Grummons. We are talking all about airway and interdisciplinary care with airway treatments with an orthodontist, a very skilled orthodontist, a world-renowned orthodontist is Dr. Duane Grummons. So I'm going to let him go ahead and share and know that this is going in deeper into all the different facets of airway treatment. And if you can stay on, great. We're going to answer some questions at the end of this. Looking forward to collaborating with Dr. Grummons. Thank you, Dr. Grummons.
Thank you very much, Jenny, and we'll continue on. Jenny assigned me the 4 categories, which we've gone through 3 already. The early signs, so it's all about earlier intervention, so we emphasize that. Then posture and airway, so the teamwork there, the integrative care, how much I rely on physical therapists to help our patients, and I can't complete these cases at all without your help. It's very important guiding care, so thank you for the teamwork. And then malocclusion, we talked about airway and some other genetic factors, and then epigenetic factors, began to get into that. And now we're talking about real life. We're out there as a team, and let's take a look at some of the patients that come in and what we do. So up to this point, we hopefully have intervened if needed. So the kids are active. They're leading their life as a child, and we have to do whatever it takes on that 2 to 7-year-old when the jaws are growing actively, and we have a chance to make big influences and change their wellness or provide wellness, be part of the team to provide wellness. And we don't know what we don't know, and what we do know isn't enough. So we have to get the rest from our colleagues, and we rely heavily on our colleagues. We want to treat patients individually, so we differentiate. It isn't like one cookbook or one way of treating orthodontic patients. No, I want to have a whole number of therapeutic approaches, and then I want to have it be specific for the condition of the patient, the facial type, and the conditions they present with, so that it's going to give us a good degree of success. And we want to measure it. We want to study every case afterward to see what worked, and if something isn't complete, then start asking the why. But we want kids active, and now the baby teeth, we've done some things. We're in the mixed dentition phase, 7 to 13. And no matter when we've seen them, the goal was to get the lips together. And so we said the mouth is for eating, the nose is for breathing. So lips together, tongue up, lock, in place, fully on the palate, nasal breathing. And then that helps the face certainly to grow. And we need your help to teach them that. We appreciate that. So diaphragmatic breathing, use of the precors, just have the not belly breathing, but teach them how to deep breathe, inspire through the nose and exhale through the mouth. So pretty basic stuff. So we'll say a few things, but rely on the therapist to teach them. And so sometimes the posture is so compensated because their head is forward, reaching for air. We want to get them chewing hard foods, chewy foods, make the jaws work, make the muscles develop, get the head upright. In fact, I walk daily, and I do my aerobics, do my exercise daily, but a lot of times I'll be walking and somebody is going slow and all that, and they say, teach me about walking. You're upright, but I actually do teach them about walking, which I've learned from you guys. You want to have head upright, shoulders back, nasal breathing, exhale mouth, walk fast, arms swinging, toes pointed straight, all the things that have to do with a good gait and good posture. So these little kids need the same thing. So a lot of times they're not even exercising, sedentary life. So get them active. Sometimes we'll suggest this little harness that they can use to kind of help them know what the posture is and do some work. Have a little simple appliance in the mouth. They're usually gamers. So we'll have to talk to them about that posture of sitting there with their face in the phone or the device. So that's part of the conversation. So we see the shoulder blades out, so the scapula rotated, and so we'll take a picture of that and show mom. She has no idea that what that means or why that's important. Neck curve, just all of that. So let's get some help from the physical therapist. And then also to get the nose working, nasal hygiene and irrigation is really important. And I first learned this back in the 80s when I had an ENT doc, Dr. Murray Grosson, next to me in our office location in Marina Del Rey. And he'd invented an irrigating device that went on the water pick. So then it was the water pick with a little tub of water that you flushed your mouth with, but he put a different tip on that had a nasal irrigating tip, a kind of a bulky part that would fill up the nary. And so you use it on each side and let it rinse, go through the whole region and just come out the mouth. And awful as it sounds, it was effective, and I became a fan of daily nasal irrigation. Not too much, because we need the mucosa, we need the mucus to help do what it's supposed to do, but to remove the excess and cleanse. And so I use nasal med. You can use clear, you can use other things, but I support myself with supplements. So I take different immune supplements. I haven't had a cold, I'm going to say 10 years, and I still get a sniffle now and then. I'm on flights all the time, like you are, and around people. And healthcare, we're up close and personal. So, we're going to be encountering things. But I do all these things for my own benefit and immune support. And if I have an onset coming, I'll take more for those 3 to 5 days. I use with patients and myself sometimes. We'll use the fluticasone or fluticasone, however you say, stuffy noses and stuff. We use this short term, even the Vicks inhaler short term, Zicam short term to help keep the nose clean. Echinacea, Golden Seal, immune supplements. I use these. I use just daily support, but if I have something coming on, I'll use a bunch and hit it with it, and it passes. If you have patients that have difficulty nasal breathing, we'll use nasal cones. On the kids, we use soft ones, but on older, like teens and adults, we'll cut this in half. Lower right screen, you see the two halves where I've taken the bridge portion and cut it out so they can individually put it in. And almost always there's one side that doesn't nasal cycle as well as the other. So we might just use it on one side for the patient on the problem side, or deviated septum or turbinate's different. So that might be the side. We like these, and of course you can use the nasal different magnetic or the tapes on the outside to help the nares because there's nasal collapse. The nasal valves collapse on a lot of patients. And everybody should have a speculum. So we highly advise that you purchase a $10 speculum and use it and look up the nose, take a picture of what you see, and have that as a reference in your clinic, but also have it to show the mom and dad the condition and then why we need certain things to happen. Also, you can take it and do in-service at hospitals or community events. There's a fact sheet that I've created. You'll be welcome to share it, but it's just a few facts, and there's 2 pages of it, front and back. It's what we hand out, but it emphasizes who the team are, so you'd put your key people on it. But it just speaks to the basic childhood problems of sleepiness, mouth breathing, breathing problems, and then other related conditions. And it brings a lot of attention. There's also the Ferris, which you can download and go get. And there's a little video that Nicole Goldfarb has done where you can get on YouTube and watch her explain the use of it. But it's real simple and useful when you do in-service or community events. It brings a lot of people into your practice. Some more wellness helps. These are, you're looking and saying, my goodness, the guy must really be ill to be taking all these, but it's what keeps me well. And so all these things are in my armamentarium of what I take. Some you take with meals, some you take in the morning empty stomach. So you time it and stage it during the day. The Curamed or any kind of curcumin is really important for inflammation. So these are the things, vitamin D, magnesium. The magnesium form of the glycinate is preferred. There's a lot of magnesium forms, but glycinate is the one you want to know about. Okay, let's talk about the different skulls now. So 3 main types: the wide face, the brachyfacial or uroproscopic, meso, and then the long face, the long tapered face, the dolical or the leptoproscopic. So 3 different skull types. Well, we know the brachy face, the big wide one, that's the one we favor. We think there's beauty compared to the long tapered face. Then the right screen, you see the meso. It's beautiful and very common. The dolical tapered class 2 face is the trouble category. A lot of things we can do and need to do to help them early. So even in utero, and then soon, this face doesn't grow and catch up like the one I showed at the beginning, where it was a brachy face and it grew robustly that first 2 years. So this guy's got a tapered face, mandibles back, airways compromised. A lot of parts aren't in harmony. So we need to help this guy young and help him throughout all those years. And the face diverges. So you can observe in your clinic, just look at the border of the mandible, the bend of the mandible, the mandibular plane. When it's bending open, becoming more divergent, it's also rotating back and the hyoid's going with it. And all this is in anatomy is encroaching on the airway. Tongue's going with it. So we want to give attention. This is something that we routinely have located on our cephalometrics all these years. And I really learned this from Dr. Ricketts in the late 70s. I took all his courses, but he was the first I heard give any attention to the airway and then to the hyoid and other factors in the face. And of course, Rick taught us how to analyze facial structures to predict and forecast the growth of the face, which we still do using computer programs. And you can outsource it. So it's just that in fact, Jenny, remember we did long range forecasts, although the images weren't taken in the posture we wanted, but still it just makes the point. We can forecast to maturity on a kid. So notice in the square jaw, the brachy face, the hyoid, top left picture is forward of that vertical line. It's called a pterygoid vertical, but it's a pterygoid region posterior to the maxillary base. But it's a very important anatomic region that's a reference area and reliable. Hyoid's forward. The more the face tapers open, the more that hyoid moves behind that line. So you see lower left image that the hyoid is way back, which tells you all the musculature and the tongue are obviously back in the airway, and the head has to, uh, we have to flex, neck extension, the whole thing. I mean, head extension, neck flexion, head extension to accommodate that. So when we bring the mandible forward, or at least the chin forward, we're going to do the surgical procedure high, and sometimes even at an angle, a tapered angle. And Jenny, is my mouse showing up on your screen?
No, no. Can you
It's
see
on top
mine?
center. Top center. It's not
Oh,
there. Okay, so I'll do it by explaining. But on the right side, we're going to go from yellow line to blue line. So we're looking to lengthen it to augment, but we're running to take and kind of wedge the chin button. So it wedges up and slides up and forward. So we get more draw and more relocation of the hyoid. So we don't just bring it forward, or we don't just put an implant on the outside of the mandible. We want the chin button above the genioglossus, the genial tubercles. We want that region to come with it. So it brings the musculature with it, and it brings the hyoid with it. So the surgery is like this. On this example on the right side, intraoperative, you see a wedge of bone that's been put in there. So we've actually taken a wedge from elsewhere and put it between. So there's two stages. The chin, the middle part's been brought up, and the lower part's been brought up more. So it's kind of like two steps to get the chin even more forward, to get the hyoid up more, and to balance the face, but to change the airway. And so these examples show what happens when we do imaging, and these are soft tissue programs that we load the images into. So we use Dolphin 3D software. So you have to take it from whatever system you're in with your cone beam over to Dolphin because it's so much superior. And you can also do it with other software that exists in the marketplace. But we happen to use Dolphin and we like it a lot. But the axial view on the lower part of the screen, just by bringing the chin up, you see the difference in what it did on the axial view for the airway. And so it's really opened it up.
so you're
And
saying this is not orthognathic. It's just at the
no,
chin?
it's just the chin. You see, if you look close, I wish my pointer would show, but you see the break in the chin on the right top screen where
Yep,
the chin has been brought forward.
I
And
see.
just that change produces that much improvement in the airway.
Not realize that that could change it and that it wasn't just aesthetic.
And aesthetics are beautiful, it makes a difference, but the purpose was to help his sleep problem, and he was a grinder. So that was, that was resolved by making this change. So structure really matters. And we talk about craniofacial structures and orthopedics for these structures. And so let's talk about the maxillae. There's two, right? It's a pair of bones. The mandible is one bone, but there's a right and left maxilla, and they're not always the same. One can be wider, one can be longer. So we think about the tip, yaw, and roll of the midface, meaning the width and the pitch and so on. So we're not symmetric on both sides, but people don't notice that unless they measure for it, unless they're looking from the coronal view and then actually analyzing some way to see. And we take one half the face and treat it differently than the other half, because if they're different anatomically, then we're going to have to do something different therapeutically to overcome that and make them as symmetric as we can. So all these bone and all these sutural regions get affected. So we're going to put something in, we're going to separate the suture. Sometimes we'll add micro-assisted or TADs to these, but on the young patients or where the need isn't so great, we'll do this. And on the lower right screen, if you look at the base of the cranium of the nasal cavity, you see how it's separated right at the base of the nasal cavity. So the whole nasal floor is changing. And we want to go slow when we're doing that to get that change. If we go too fast, the expansion of the teeth and the jawbone or the alveolus expands, but we don't get the nasal change that we're seeking. So we go a little slower to let that happen. On young patients, it's ease a little bit goes a long way. It's very easy. Top left screen, you see there's arms that are on the appliance on the outside by the canines. Those arms are going to a face mask. So when we're using this for width, the face mask is on at night to protract, to bring it forward at the same time. And of course, if the sutures are being stretched and growing and stimulated, the face mask works all the more quickly because the sutures are mobilized. So you get a lot of change in a short time. So on a child like this with a class 3 underbite in the top center, you notice that we put little plastic turbos on the side, little composites to lift the bite. So I said we first do width. On the lower right screen is the width. So then we do height, which is the plastic lifters, and then forward is the face mask. So width, height, and forward, all at once in a few months. Voila, and we overcome and we normalize. And we always want to overcorrect, and so we know that there's a different pattern there. So we've corrected enough, just like on your son, on Clyde, it would have been overcorrect more, knowing what growth was yet to occur. So we have to overcome and know the forecast of growth. So we know totally the flight plan. So if we're in the middle of the flight plan, we do enough to reach the destination. We can expand both arches. They go slow. And of course, the lower is mostly dental alveolar, but we go slow and gradually bring things into place. And then the how-to for orthodontists and colleagues is in different journal articles I've done. These are referee journals. So you have to put it in and prove it so that it gets published. It's not a journal where you can just put some pictures up and state what happened. This is proof. And that's what I like. So I like to publish in referee journals. And I mentioned about when we expand slowly and we change the palatal vault and bring it down, then the nasal septum is stretched. And Peter Catalano taught me this, saying that if you guys are doing this well and properly and slow and giving nature a chance to respond, you're going to help us a lot with the nasal airway and nasal anatomy. Lower left screen, you see there's 4 little micro implants, 4 little screws that are incorporated into the expanded device because this patient's older. So we need that to get the necessary expansion influence to separate the sutures and accomplish the change in the structure, not just push the teeth and alveolus out, but get the whole nasal floor and all the other sutures to be helped and to be influenced. And so this is an example, lower right, how much the nasal floor changed. 4 millimeters makes a big difference in the nasal chamber as far as nasal resistance, nasal flow, nasal function. So we want to go slow. Sometimes it's 1 or 2 turns a week. I'm going slower if I've got the face mask on because that takes longer to produce the change. So I might be in for a 6 or 9 month treatment experience in therapeutics. So I'm not in a big hurry to accomplish the expansion if there's more of a need for anterior posterior change or forward movement. Airway gets better, obviously a big volumetric change, and so the resistance is different. And I mentioned many times the two halves of the face aren't the same. So if we measure from the front, the frontal analysis that Ricketts originally developed, and I took it to be an asymmetric one where I could measure the two halves instead of just measuring across the face. That tells me J points are the width of the upper jaw. So when you look right in the middle of that little analysis, you see a J point. So one side is the width at the first molar of one maxilla, and the other side, so the maxillae, if we measured across, we might have a width. But one side might be 4 millimeters different than the other. So we're interested in the total width. But if something's 36 millimeters, it might actually be 16 and 20, not 18 and 18. So, when people talk about the intramolar width is this much, well, that's interesting to me, but I want to know how much is it on each half of the face, because I might need to design an appliance that expands one side more than the other and get the benefit to the patient. And that means a benefit in the nasal chamber and the mid face as well, not just how the teeth are. And then the lower part is the mandible. It's off center. ME is menton, the chin point, the center point. It's off center from the center line of the face. I can't see that from the side. And so we tell patients and colleagues that if you look at a house from the side, you're going to see the height of the house to the roof. You're going to see the dimension, the width, but you're going to see nothing about the entrance. So you have to get around to the front of the house to appreciate the width and the height and the entrance. So this is the entrance to the face, the entrance to the mouth and the nasal passage. But you got to see it from the front to appreciate the occlusal plane tip, where the chin is located, the centering of the smile, the width of the parts, the two maxilla, the width on each side, and then where the mandible is, and then do differential or asymmetric treatment if the face is asymmetric. So individualized treatment based on the individualized problems. And so Rick had brought our attention to this with his analysis in the 60s and 70s. I spent a lot of years measuring front images, and Rick is a guy that encouraged us, just like Mariana would encourage you or me or any of us to learn more, do more, stand on my shoulders and go higher. And that's how Rick was with me. It's like, this is a good idea. You take it and just improve on it if you can. So I appreciate that encouragement. And ultimately it got published. But Rick and I published this together. It took us almost 20 years of getting together when we could to trace these and analyze and figure this out. And then it all got published in the World Journal, a refereed journal. So it's still used today, and it's in the computer software programs. But you're probably not seeing it if the orthodontist isn't using it, because it takes a little more time. It takes knowledge to analyze it. But once you get it, it's just a few clicks. It's 2 minutes or so to look at it, view it, and understand what that patient has. And then we take that to the clinic and then have it affect our treatment. So it's very important. Class 2 with the lower jaw deficient, these are the ones that need a lot of help from us as a team. So we can do things to bring the lower jaw forward. So we expand the upper, bring the lower forward. So it's width, and then control the height. So the smile's going to be in the right place, the teeth and all the parts in the right place, and then bring it forward. So a beautiful change in this girl in the two phases of treatment. But the airway, early orthopedics first, earlier, and then when the teeth are coming in, and then retain at the end. But a nice change. What we often don't think about is when we put a growth appliance in to bring the mandible forward, the reciprocal effect is it's pushing back on the midface. So if we put a Herbst appliance in, or a Mara, or different appliances that posture forward, the muscles are trying to bring the mandible back, and the appliance is engaging the teeth. So the mandible is trying to recover back to get to the muscle contracted length. And we've violated that in a way. We've basically postured forward. When we swallow, it's trying to come back, and it's pushing backward on the midface. So oftentimes we'll put a face mask on to keep the upper jaw neutral, or to keep it in place while the lower is being changed. And it takes a long time for the colleague to understand that. They're saying, the lower jaw comes forward. Why would you be bringing the upper forward? It's to offset the reciprocal forces of that appliance that's in the lower third of the face. and all the muscles of the lower third. So that's the why. So let's take a case example, a young little boy. He snores a lot. Remember, we said if they snore, you have to do more. So if they snore early, we're going to intervene early. He's a class 2 mandibular hypoplasia, underdeveloped, airway compromise, which you would expect, and the cervical compensations, which you would expect. So this guy's in early, and he's going to get surgery early because he can't sleep. He falls asleep in school, not able to advance in his grade. And the family has a lot of athletes and big people, and they want this kid to have his best chance in life. So he comes early, referred to me by another colleague, and I started early on him. But I told the family we're going to do the jaw surgery when he's 11 or 12, and everybody you talk to is going to tell you that's crazy, that we've lost our mind, that go get another opinion. And I said, please do, so that you can come back and see the why. What we're trying to do is treat the airway and brain function and neurocognitive and have him sleeping and thriving. After the surgery, he grew 5 inches in the next year, the next school year. He grew 5 inches because now we're getting metabolic normalcy, we're getting sleep, so we're getting the growth hormone, we're getting all the stuff that happens in sleep. And he would have grown anyway, but he grew more than his forecast. He was supposed to grow 2 point something inches. So anyway, the point is it helped him thrive. So the jaw's forward, and why 11 or 12? Because the 12-year molars, I wanted to get those sufficiently developed so that the osteotomy wouldn't injure the 12-year molars. And then third molars, buds, they can be taken out at the same time. The surgeon is in that region anyway. Just take out the third molar buds, complete the osteotomy, advance the jaw, but not injure the 12-year molars. So look at the C-spine. Look at the change from bringing his jaw forward and normalizing the parts. We did not advance the upper jaw, just lower. He had a good chin, so we knew that would be sufficient. But I love what's happening in the cervical curvature and just that change. Any comments, or Jenny, on what you see in the neck?
Oh, yeah. Then, I mean, the neck, the one on the left is definitely very compromised, but it's in the lordotic curve, but it's definitely very, very compressed. The neck on the right is a little bit better. The space between the suboccipital, CUO, C1, C1, C2, you always want that to be, equal. You can see that there, but definitely there's still work to be done on both of them.
Yeah.
Yeah.
And why is there so much problem 5, 6, 7, just much lower down?
Yeah, so it looks very straight on those in that
Yeah.
level. So there's a like an extension curve right at like the C2, C3, but then right below that it's very vertical.
Yeah.
Very,
Yeah. The red line is just straight.
yeah, yeah, yeah.
But anyway, it's a lot of improvement. And his remark was, I'm sleeping good. Now, I got some videos that show this, but for this talk, I left them out for time's sake. But the kid just grew like crazy. And then all of a sudden, he's this big jock, the athlete that he wanted to be. And this is eighth grade picture. So we
Wow.
operated him between seventh and eighth grade that summer. And eighth grade's the year that he grew 5 inches in that one year. So sometimes you have to operate early when there's really severe problems. So again, the surgeon's going to see this case and operate both jaws and chin really early for the sake of the person thriving. Okay, let's go into class threes a little bit. So even on the very young patient, like the lower left screen, when the patient smiles, you're seeing the lower teeth. And of course, we want to see the top teeth when you smile. And as we age, the face slides. So if you look at newscasters that are in their 40s, ladies might still be showing the upper smile pretty, but the guys are starting to show the lower teeth. When they're 60 as newscasters, all of them are showing their lower teeth primarily because the whole face slides. And basically, it's like pulling the drape down on the window. So the soft tissue drape over the teeth slides down, and the lower teeth are now displayed more than the upper. We lose about 1 millimeter of smile display every 10 years. So when we set the smile up, we want those upper teeth well displayed and seeing the gum line so that we are planning for the aging of the face so that the smile is pretty at 50 and 80, although it will change. So these two people, here's a young guy, probably late 20s, maybe he's 30, but all lower teeth when he smiles. And so when you see your patients coming in with lower teeth displayed, that's another clue that the midface is deficient, not only AP, but vertically, because the teeth are somewhere up under the lip, but so is the jaw. And the upper jaw happens to be the nasal airway, happens to be the pharyngeal, the turbinates, everything connected all the way back. And if we see this little girl on the left, we're concerned, is she going to become the girl on the right? And we shouldn't have to wait and see. So a lot of colleagues are, well, let's check him in a year. Let's check him in a year. We should know right then what the flight plan is or what the forecast is to be able to show them, here's the problem we have. We're just in the first phase of it, but this is the problem we have and what we need to plan treatment for. So on the midface deficiencies like those, we don't want an appliance that puts a compression on the chin because, as I explained, it's pushing the condyle back, which is compressing against the posterior attachment, not the load-bearing zone within the joint. So it violates, collateral ligament, posture, disc condyle relationship, all the compressible tissues at the back, and so on. So it's an unfavorable force and it's sustained. It's on there for 8 hours without jaw movement. And so would rather load the forehead and the zygomatic region, and we'll put little extra cushions under it so it's soft and comfy, and teach the kids how to put this on and off themselves. And the crib in front isn't at the lip level, it's almost always below the lip level, so that when we have the elastics on, the elastics aren't straight forward, it's actually at an angle, a tangent coming down and forward. And of course, the elastic, when it's attached, it pulls back on the crib a little bit. So we want the crib intentionally lower so the elastics are away from the lips and they're drawing the midface forward and downward. So in the end, the teeth have come forward and down and they're displayed when the case is finished. So in the top left, you see width going on with the expander. You see the height by the turbos, the plastic lifters, and then you see we're overcoming it with the face mask. So width, height, and AP, forward movement, all three at the same time. So it's tip, yaw, roll. And then the direction of the maxilla, if it's tapered up, we're going to bring the front down. If it's already level or down a little bit, then we'll keep it that way. But almost always it's going to have, the back will be lower than the front. So we'll have to bring the front down to bring the teeth with it and display. And then we load on the orbital region. The zygomas are beautifully designed. They're big and thick and strong, intended to take impact. So they're strong supportive regions. And then does it work? So then the proof is having people research it and publish in different journals. So this is just a splattering on the screen to show that almost consistently, all the reporting, 94 and Gupta's work and so on, the airway, the midface comes forward 3 to 4 millimeters at 0.8 typically. And the younger, the more that we're going to move it forward. If the kids 10 to 18 years of age, we're going to get almost no forward movement of the point A. We'll get the teeth and the alveolar bone to come forward. But if we want the structure of the maxillae to come forward, we've got to start early because that face is maturing earlier than we think. So we want to start early to get that kind of change. But 3, 4 millimeters is a lot at point A, and it's a lot in the dentition as well. So starting early like this, ages 2 to 5, simple appliances and simple wear, and then get out of the way for 3, 4 years, come back in when their teeth are coming in. Most of the time we use aligners because the cases are so easy, or brackets if that's preferred by the family, but it's an easy finish. So this case was used when the ADA was first establishing the CAST program, and different colleagues went in. Barry was one of them, of course, and Barry asked me to give him a case to take to the committee to present. So this case went there to show why we want to see these kids in the very early dentition, class 3 midface deficiency. So we get our cone beam, there's not room for teeth, but there's going to be. Oh, and grandfather's an orthodontist. He actually flew in from Monterey to the Spokane office here. And he did that for the whole year while we treated her because he wanted his granddaughter taken care of. And he just said, I don't know what to do really. I'm not into airway, but you are. So she came up with him and it was great. What a privilege. But in a year, this is how she was. And then we get out of the way and then come back in later to finish her. So she's grown now. But this case went to the committee along with other cases to prove what we can do. This picture is Mariano when he had come the one of the visits to the office, and we're sitting there going through casework and tracing him out and proving what we're doing. And he was very curious and knowledgeable for sure. The guy knows everything. So I learned so much, a wonderful experience. But this brother and sister were in treatment. So I had Mariano fit their face masks and then go through the case together. So that was fun. Now, interesting, I sent this to you. You might have seen
Yeah.
an email. It just came, but Paulina is a patient of Mariano's in Chile right now. And this is September 10th. You can see the date up there, but she's writing to say, my son has been wearing a face mask on the chin and he's very sore, uncomfortable. What can we do? And so Mariano said, reach out, and we're helping her. So I've been in touch and we're going to guide the treatment with her orthodontist in Santiago. So what a privilege. But this is because patients struggle when there's something on the chin for a lot of reasons. And so we want to help them. Another case example where this girl was width with the expander, height with the vertical turbos, and then forward to get a pretty face. So we're at the end of the slides. So let's say that we enjoy the finish, we get a nice smile, and we want to keep rising and keep thinking, keep learning, and we'll see you at the top. So we'll take some more questions.
I love your see you at the top. You keep sending me that and it makes me smile. I want to just say, I just realized there's a bunch of questions that I
Okay.
missed last time. So we have a lot of questions. Here we go. This is one about the CBCT. On a CBCT, what observations might stand out in a child with OMD? A myofunctional disorder, oral myofunctional disorder. So what are
Sure.
the things that you see regularly on these CBCTs for children? And what kind of things would we look out for?
Well, I wish I had a pointer, but you're first going to look in, you're going to examine the patient first before the CBT. You're going to prescribe it. We don't just have them come in and everybody gets a cone beam before I've first examined the patient. I think we need to look first, and there's a different field of view that we can call for, different resolution. There's things that we can do in taking the CBC to have a LARA principle, reduce the radiation, be concerned. And then the region of interest. We might need the full volume because we want to get down to hyoid. We want to get the whole cranium and the whole, C5, C6, 7, however low we can get. But on this, we'll see soft tissue. So we looked in the mouth to see soft tissue, and then over to the image, we'll see the tonsil, adenoid. We'll see up into the whole sinus region. We'll see the tip of the maxilla. So you can see on the top right quadrant, you'll see the bony tip. Front teeth are where they are, but there's a whole tip there, a cant. We'll look at the C spine on these images. Then we'll go over to the axial view. And actually, the first one I look at is the axial view. I'll scroll up through looking at the axial view first. We're all tempted to want to look at the lateral view because that's how we see the patient and plan our treatment so much from the side. But I look at the axial to go through and look for pathosis and look at anatomy and look for variations, look at the sinuses, certainly, look for nasal collapse, go up into the base of the skull. And we found things, and we'll send these out for reads with a radiologist so that we get reads. Not all of them, but I would tell you medical legally, because there's 33 cases I've been one of the experts for that have been in trial. And you want to have a report existing in the patient file, a radiology report, and you can generate it yourself once you get skilled and learned it enough to generate it. And it's another reason why, if you have limited field of view, that you're responsible for reading what is in your specialty for that region. But when we get into full volumes, I want the help of the expert, of the maxillofacial radiologist to read those, and they'll use them as a tutor to read what they've written and what they see, and then go look at it and find it. But we're looking at soft tissue in the mouth, in the patient, on the face, and then we're looking inside on the images, axial. So I think she asked, or the person asked, what do we see in general, or was it soft tissue?
It
Was there?
says what might stand out in a child
Okay.
with
Yeah,
OMD?
I look at the airway, the throat. I'll look at the cant or the direction, the divergence of the two jaws, upper lower jaw. Look at the teeth where they are relative to the bony support, the housing for those teeth. Are the teeth flared and they have thin bone support? Is the upper jaw narrow and the teeth are near the perimeter, thin bone support? Uh, and from the front, is there anatomy variations, asymmetry, which I'll see from the front? Those are the key things. And nasal collapse, I mentioned that a few times, but the nasal valve and nasal collapse is important. I want to scroll through the turbinates and see that whole region from the front, look at the ostium, and of course, inside the sinuses, always
When you say nasal collapse, I'm sorry to interrupt you.
nasal valve.
Can you see that in a CBCT, the nasal valve collapse?
You don't see it well, but you if you've got full volume and you are outside the anatomy, you can scroll in and then
Okay.
tip the volume. You don't have to be purely lateral, front, and axial. We rotate the whole volume, so we're looking at it from different tangents, and you see a lot of things. So you can tip the head up, look right up the nasal chamber, and have some appreciation, like in the top left. If I took that volume and I tipped it down a little more, so I'm looking right up as you would with an instrument, I can have an appreciation for that. It's much better clinically, and it's much better to have them breathe in and out and other tests, to appreciate the collapse if there is. But
Yeah.
and
We
then a key thing I would tell you, we make a lot of screen prints to fill up the chart with all screen prints of things we find and observe. But I've learned over the years that our first CBCT we got in 2004. So we were one of the first platinum ones, the cone beam platinum type. But we got the ICAT then, and then since then we got the upgrade and got another one, second one as technology changed, it got better. But the point is, I learned to take screen prints and print a few off and put them in the mail, old school, because you digitally make them and send them, secure and all that. They're in the chart. And today in my chart, we put it there and so on. And the doc sees it, a technician opens it and does what they do on that end, but nobody sees it. And the reason we send them is somebody opens that and there's a nice glossy printout on photo paper and they see like this image on the left screen and they go, oh, this is amazing. And they look at this, they show it around the office, and guess who starts sending patients? That office immediately goes, this office is doing something different. Our patients are going there. And for a lot of years, I was doing not all, but I was doing most of the 3D imaging for an ENT office of 7 docs. So do you think I got quite a few help referrals from those 7 ENT docs? Because a lot of questions are, how do you develop a relationship with the ENT doctors? So I went there and did in-service, didn't go very well. There's only 2 guys that kind of were interested, and it was just probably courtesy. And as soon as I got this kind of stuff and started sending them information, even though I sent pictures before that, histories, reports, didn't really do much. But once I got the cone beam and sent those copies, it was stuff they didn't have. They started referring to get the imaging from me and then to work the case together. So it's just a suggestion.
I go very good too. So one of the things that we look also for adult and children, but it's the upper cervical spine position. So we want Atlas to be in neutral. Normally, these forward head postured, open mouth postured children have deviated septums and condyles that are not in that optimal forward and
Yep.
forward position into the joint. So you look at the condyle, what position they're in. The atlas, if it's rotated, you have more space on one side than the other. So we
Mhm.
kind of look at, as physical therapists that treat head and neck, we look at things. I always look at the airway in general, be it the nose, the throat diameter, the position of atlas, the position of the condyles, and how bad the bend is in the nose or the septum is.
Sure.
Those
And
are great.
I would have TMJ images, which aren't on screen, but there'll be a whole series of TMJ views from all 3 aspects. And then you look at side bend probably and C2, all
Yeah,
that.
what
So
happens there? Yeah.
we scroll through to that and then take a screen print of that too. And then it goes to the therapist or it goes to the PCP to get approval for PT on medical insurance. So we use that to help them understand, and it's just automatic. We also use prescriptions in our office for PT or speech, SLP, for anything. We have prescriptions that are pre-printed, and then they're signed and everything's ready to go, electronic. Used to be paper, but they're ready to go, and we check the boxes that apply, and then the image accompanies, the history accompanies, and it's off to the doc, and the patient's off to the therapist.
Wonderful. I have another question for you, Duane. This is, if there's a deflection of the mandible, does that typically necessitate not just transverse expansion, but opening of the vertical dimension as well? So if there's a deflection of the mandible, does that typically necessitate not just transverse expansion, but opening up the vertical dimension as well, is the question.
Is this maybe the slide? Because
Yeah.
there's a width problem more on one side than the other. Midline's way off, as you can see.
Yep.
So we expand one side more than the other, but yes, the lower needs to be expanded and differentially, one side more than the other. But even if it wasn't this case and we just had both arches narrow, we're going to take the front view and we're going to scroll through at the canine region and go through at the molar region and measure. And then if they're leaned in, typically Curva Wilson it's called, but they're leaned in, we're going to have to upright those. And a key thing to know is when we expand with primary teeth in place, the roots of the primary teeth are down in the alveolus. So when we expand at the tooth level and the roots are influencing the alveolus actually remodels. It actually widens. In Europe, they call it warpage. It warps. And that's where I first observed it and learned it, was speaking at a German meeting. One of the docs his topic was alveolar warpage. And that was basically remodeling by doing things on the primary teeth. That doesn't happen when it's permanent teeth. So another reason to intervene earlier when they still have primary teeth, so that when we expand, the alveolus develops more, and so it's a bigger perimeter for the permanent teeth to erupt into and more chance to be non-extraction. But it's a nice wide bone base for the teeth to come into and have proper bone support once the case is finished. So expanding younger is better for that reason too, and periodontal support.
Great, great. Okay, I have another one. This one is the prevailing thought that the tongue resting posture is what leads to an open bite in the setting of a tongue thrust rather than a tongue thrust swallow. So is the prevailing thought that the tongue resting posture is what leads to an open bite in the setting of a tongue thrust rather than a tongue thrust swallow?
Well, I think I would back it up to say, why are we not using the nose box to breathe? And why do we have to have the tongue low and the mouth open? So I think I mean, the person knows more about it than I do just by the question. But my thought would be, it's probably a case like this. Would that make sense, Jenny? Is this maybe
Yeah,
what's,
to me, whenever there's a forward position of the tongue and the tongue's trying to get away from the airway, trying to create more space.
yeah,
Um, so the question, I know that tongues like to create little splints between the teeth,
yeah,
and
yeah,
they kind of help stabilize the teeth. It doesn't mean it's a good thing because it does create an open bite.
right.
I like it should, that to me means that there's an airway problem. This patient is moving their tongue out of their mouth to create more space, to be able to breathe better, and they're starting to move teeth. And they're probably going to swallow in that position and make that opening even more. So I don't know
Right.
if it's just the position, but they probably will thrust um, in that position. If that's the starting position of the swallow, they're going to probably thrust through the teeth also and create more of an open bite.
Yeah. So I think hopefully I'm on the right examples, but I think this and this, just like you said, I think airway right away. I think, why is the mouth for breathing instead of the nose? And if the nose was for breathing, the tongue could be in its place eventually. But also I could do the orthopedics to change this environment and this relationship so the tongue can get placed properly, and then the lip seal and the use of the perioral muscles properly. So all that stuff is in my thought
Yeah.
rather than just which swallow is it? I'm thinking airway also, and all
Right.
the associated things, the
Yeah.
OITs.
Yeah. Okay, I'm going to go to the next one. Do you know where I can read more about septal deviations reducing with expansion?
I would go online. Peter Catalano, Catelano. Peter is ENT, was in Boston. He's retired in Sarasota, Florida, but he is one of the most published and with all the microsurgeries and so on. And Peter has done a lot of publications with John Walker, who's an orthodontist, and the two had teamed up for a long time and still are teammates in treating patients. So they're in the Boston area, but Catalano and John Walker. And if somebody can't find them for some reason, write to you or write to me. I'm Grummons at ME. I put it at the end of the talk, but just we'll help you. But those are two of them, and there's a whole lot more. But once you
I
see them,
met John Walker. I met him and Peter this year. We did a collaborative, like multidisciplinary thing in Florida
you
for
and
the
Peter did.
yes.
Oh,
So
that had to be fabulous.
we did this thing where we like collaborated. Everybody thought like talked about what they thought was important in their field to make sure that the patient understood and went through treatment. So it was really neat. But I met John and he was a hoot. I really enjoyed
Oh,
him.
yes. No, would you recommend Peter as a reference for
Oh,
this?
absolutely. I've
Yeah,
I've referenced Peter all the time
yeah, me
when
too.
like the Starling's resistor model, like he went
Yes.
through that research. Like basically bruxism, right? I always tell patients like if your nose is not working, you're going to have more
Okay.
bruxism. So, and he did that whole study on, 25 patients, 25 children and adults doing surgery. That was his only treatment. That positive bruxism, the kids all stopped bruxing with nasal septum and turbinate reduction, just opening up the nose. So
Yep.
so that to me, it's like if you we have to start thinking differently when it comes to alignment, posture, head and neck, tongue position, all of that. There's some underlying reason that that's happening. So to me, I think the CBCTs are really critical and important to
They
really
are.
understand the structure.
And
Um,
I'm going to suggest Karen Parker Davidson, KPD. I mentioned her earlier, and in these two images on the lower screen, you see that middle image? So that's on a cone beam scrolling through, and the volume's rotated, and you can appreciate some difference in the nares and so on. And then internally, certainly the left lower image is appreciative, but I would chase after Karen's publications and her books. And
yeah.
she's a wealth of knowledge and so up to date. Oh my gosh, she's dynamite.
Okay, let me go to the next one. In myofunctional therapy courses, we are taught to expand first if the tongue cannot fit into the palate. At Dr. Hobson's recent course, I learned that some practitioners wait on expansion until patients have established mouth closure and nasal breathing. Do you have a specific order in which you prefer to complete intervention with expanders? So
Well, I,
she's talking
I
about
think,
Dr. Simon Wong, who I worked with a lot with learning the
oh,
GOPEX system.
mhm. Yeah.
Dr. Wong, he is strict about his patients not going through any kind of ortho until they close their mouth. And the idea is that once their mouth are closed, putting something in it will there's a better chance that their mouth will stay closed rather than starting with an open mouth posture, putting something in when their mouth is not used to being closed and having that go through expansion with the mouth not used to being in a closed posture with the tongue in the right position.
Well, I don't disagree with the thinking. I disagree with the clinical management. Uh, I mean, this would be an example, asking this patient to do lip seal, swallow, nasal breathe, do all the things that you would want, get balance of musculature, which is not possible because the lip is going to entrap, lower lip entrap underneath the overjet of the teeth. So I would tell you that for 12 years, I had a speech SLP, a speech pathologist on my staff in Marina Del Rey, Debbie Brady, for 12 years. And she had her practice, but 2 days a week she'd come over and be in our office. And her input in therapy was so valuable. I just said, if you'll do the therapy here when the patients come in, they pay you no rent. I just need the therapy that you provide, and I don't want the patients to not show up when we refer them. They go sometimes, and sometimes they don't. This way, it's part of the treatment. But I can tell you from those experiences over 12 years, routinely, she wanted me to begin to change the environment, get the structure closer to what it should be, and now bring her on the team. And she could accomplish her changes so quickly because parts were beginning to match. And then as she had her therapy involved, then my therapy would be more accelerated as well because parts are matching, function is becoming optimized, normalized, optimized, I like. But by that time, nasal breathing, all the stuff. And even um, I've got a little basket of goodies, but even these little stir sticks like you would have at Starbucks or something, even part of it on that kind of a patient, when they're at home, they're using a piece of paper, a toothpick, anything like that, and they're sitting with that between their lips just to remind them that we need your nasal breathing, tongue fully up, the GoPex things. But we intentionally, for success of clinical management, get the orthopedic started, make the referral so that they've met the therapist and know the problem. And if the therapist wants to start, that's fine. But the second thing I would say is we've had so many times where they are attempting something at school a year or two, trying to get speech better in the classroom. And finally, they come over and we start our changes and say, just pause that for 3 months, please. Let me start our orthopedics and then trigger your treatment again. And things get resolved very quickly. So the clinical management side, I think, tells me I would do it this way.
Yeah, so and you just mentioned I taught this a lot in the course that I just was teaching this past weekend. We put it under the tongue. We create a suction above the tongue in
Nice.
up block, right? So it's
I
up block,
like that. Yep,
teeth
yep.
apart, lip
Good point.
seal. I like this because you have to close your mouth to hold it in your mouth, but you create that suction that will support the back of the throat from
Good
not
point.
falling. So yeah, good question, Kate. I think it's also tricky to do any kind of nasal breathing, tongue oral posture when there's an appliance in the mouth. So how do you manage when the patient's dealing with appliances and you have a myofunctional therapist working with them, training their nasal breathing, training their oral posture? That's always the tricky part for me is when they have something in their mouth and they're not good at all these things quite yet. But it's hard to uplock around that. It's not
Well,
impossible, but it's difficult.
it is difficult, but I think it comes back to us appreciating what you just said. So our appliance design has to be miniaturized as much as we can. And we have to be smart, get in, do what we need, and get out. Or we might use two appliances, like use the first one, which when the palate's narrower, it might actually not be as high as we'd like it, or use a smaller one to get 50 or 70% of the change, and then make a new one to take it the rest of the way for the sake of having a very thin mini appliance to accomplish the change. A lot of colleagues aren't willing to pay the lab cost, and the lab cost isn't that much. But for the sake of the patient succeeding and being able to accomplish the therapies, I'm going to do that every time. So these appliances that you see, they're fairly small, they're thin. Nowadays, there's a lot of choices from companies. Leone company makes the expanders, Dentarum makes expanders, but they have a long, long list of choices. So we can get small ones that are efficient and miniaturized. And we use a lot of occlusal rests. So you see that there's little arms going across the tops of other teeth or around the sides of teeth, and we can bond those on. What a lot of doctors do is they'll make something that's rather large, 2 to 4 teeth, have bands or braces on them or something, and they're kind of big and clunky, which competes with the tongue space for sure. So if we have little wires here and there that we can bond, it secures the appliance, but it lets the jack screw and the parts of the appliance be very miniaturized and placed off to the side, not so much in the midline. So I think our design matters. And I think we should be smarter as clinicians to try to provide these so that the patient can succeed with the other collateral therapies.
Agreed, agreed. Okay, I have another one. We have a few more. Um, this is from Kate Bloom. She's a speech therapist. We see younger patients, 3, 4, and 5 years old, with deep bites. Other than myofunctional therapy, what interventions do you recommend to help these patients to get out of being trapped in this bite?
Yeah, and growth is affected too if the mandible is entrapped. So, I mean, this is a cross bite, but it's a deep bite. So, I mean, patients like this, even if they're not going to go through the therapy or don't need face mask or choose against it, I'll advise the dentist to at least do something to unlock the bite to help the vertical. So the vertical dimension is increased. And I think an earlier question had vertical dimension as part of it. So we go to rest posture of the mandible, and the freeway space is going to be way excessive. So there's a lot of room to build up the height of the back teeth on the primary teeth to establish a new vertical dimension of occlusion, a new target. And we're still within the freeway space, so it's normal. But even just doing this on one or two teeth per side, two teeth per side is best. It's like four legs of a table. It's going to be balanced so that it's easy for the dentist to do that. They can bill the insurance as occlusal composite restorations. So there's insurance support for that. And it's so beneficial to establish a new height. And guess what happens? If the primary teeth are put at that new height of vertical dimension, the permanent first molars erupt to the height of the plastic instead of the height of the baby teeth. So now they erupt to the new vertical, and that sets the stage as a new height of the posterior teeth, and all the other teeth come through to that new therapeutic height. And our vertical dimension has been improved just by doing two composites per side on primary dentition. Makes a huge difference. I've got x-rays that aren't here on this one, but x-rays showing having put those in early, and the first permanent molars just keep erupting until they hit each other, but they're
Yeah.
at the new height. And then when the baby teeth fall out, the new premolars come through to the same height. And we've got a whole different vertical dimension and lower facial height and neutral TMJs also.
Both kids had that going through. We did ALF therapy for a little while, and they did these little buttons that helped them disengage how deep their bite was.
Sure.
It definitely helped immediately. So, and it
A little
seems
bit so far, just these little things.
such a little tiny thing can help so growth and development. It's amazing.
Yeah. And you could do one per side, but the problem there is if one wears down or breaks off for some reason, you lost the leg of the chair. And then colleagues will ask me, well, should you do it on lower, do it on upper? You need two per side. If you're missing a tooth or you have a stainless steel crown on a primary tooth, some reason, or you're missing the primary tooth, or it's ankylosed or submerged or some crossbite, something's unusual, you still just have two per side, and it can be one on the top, one on the bottom, because once the jaw closes, the opposing teeth hit the plastic, and either way, you've got support two per side, which makes it balance.
Yeah. Yeah. Okay, this is an interesting one. This is a dental question, and I'm so excited to hear. Hopefully you can answer it. Can you
Hopefully,
help
I can.
can you help break down pitch, yaw, and roll?
Oh gosh, I wish I had the slides here. I mean, uh, well, pitch yaw and roll is thinking aeronautics. Pilots would know that better than anybody. But just go online, and you'll see a image come up right away. If you put pitch yaw roll, you'll see something come up that'll be an airplane probably. And so the roll, there's an O in roll. So I use that to remind me that the O in roll is occlusal plane. So the occlusal plane is this. So when the airplane's flying, if there's wind or anything, it's gonna alter its roll. But anyway, I was Air Force. My son's a pilot, and so we've been up there a lot. And he's left seat, I'm right. So he's the guy that really does it. But O is the roll, so that's occlusal plane. And then yaw, there's a M in, well, there's a W, Y-A-W, but a W is an upside down M, M for midline. So where is it at the midline? Is it flying straight or has it got a little bit of yaw because there's wind or there's some weather that makes you have to be oriented that way to make forward progress. So O is occlusal, and Ya is at the midline, and the other one is the angle of the whole maxilla or the whole plane. Is it doing this on takeoff? Is it doing this on landing? So that's pitch.
All right.
Ya roll, but just the easiest thing for my dental colleague there is just enter it in and it comes right up and you won't forget it.
I love it. I love it. Okay, there is three more questions. Can you get lowering of the nasal floor with change versus no, with change versus expansion so that the palatal vault is not as steep? Also, is there a way to measure the height of the palatal vault and what are normative reference measurements for that area?
It's not the measurement, it's to know that in a dolichal face, the maxillary plane is tipped, the pitch is changed. Um, and so in a brachy face, the maxilla is flat, many times inverted. It's very flat maxillary base, and it makes a horizontal face. As soon as the maxillae are tipping like this, the back drops down, so the mandible can't close as far, it rotates open, so it's divergent. So the palatal height in a brachyface is going to be, it's a big, high, wide palate. It's just big and wide, but it's big, thick bone, but it's going to be horizontal. A dolichal face is going to be more tapered, usually. Remember, I said there were 6 subtypes, so that's part of a subtype. But the point is, it's tapered and the bone is thin. Dolichal faces just have thin bone in most regions, thin around the roots of the teeth. It's not big and thick. The chin isn't thick. The zygomas aren't thick. The nasal structures aren't thick. It's just the nature of that face. And so you wouldn't want to have an average number. You'd want to take the face type. And we measure the height from the palatal plane to the vault if we're doing surgery, because there's certain references we can use to locate in our 3D software to move the face and know where we're going and where it was and where it is, so we can have some comparative to say it moved 6 millimeters there and 3 here and so on. So the little computer boxes move as we move the part, and we know by looking at the box how much has changed. So we use it in that way, and then at surgery we have to measure so it's the same, and then we know we got to the target, but not as a we don't use that as a measurement to guide our orthopedics, for example. It goes with the face type.
But are you saying that there is any kind of dropping of the palate with
Oh,
expansion? Is
oh
there?
yeah, there is. Yeah, definitely. I made that point, and that's Peter Catalano's point that hey, if you guys can do that, it's going to stretch the anatomy at the nasal septum region
Yeah.
because the floor has been changed. And I'm going back to that one slide I had where I measured it on cone beam, and
Yeah.
maybe that will help us right now. Um, I had the skull. I'm sorry, I just need a second. Here it is. So yeah, it doesn't show the palatal side, but that's just what happens. We know the palate optimizes changes as we get width.
Yeah.
So
Okay. Okay. I have one here from Ernesto Fernandez. What up, Ernesto? This is an acupuncturist. He actually was at my course this past weekend. Um, what is the name of the program that forecasts the development of the face?
oh, I'm glad you asked. Oh, I'm so glad you asked. It's actually the key technician, Patty, is in Florida. It was used to be called Rocky Mountain Data Systems, RMDS. And it's now, as of about 10 years ago, new ownership and relocated from Denver to Florida. Patty went with the company. She's their chief analyst, and she's an orthodontist by training. And she came here from Mexico City and relicensed and a fabulous technician. So that I would rather give you the website, but it's FMBO now. So
FMBO?
Yep, let me give it's Patty Dutton, Dutton, and I'm going to have it in a second here. So here it is, FMBODS, FMBODS at bioprogressive, one word, bioprogressive.org.
So is that an email? FMBODS at
That's
B,
where you start.
what's
Uh,
that?
I'm going to text it to you right now so that you have it. I don't know if you can post it on screen there somewhere.
I can do that. I have this chat. Hold on a
So it's
second.
Dr. Patty Dutton, and she does all the forecasting, long range, meaning to maturity. They can do height predictions even, do short term, do the key thing are the norms for a face. So any age, uh, any really ethnic norms and so on, but they'll take the face and give you the norms, what it should be, and you can superimpose them on the front or the side of the image you have to know where the proportions are not matching. It's phenomenal. And it was originally developed by Dr. Ricketts and others. And Rocky Mountain owned it and used it for probably 40 years. And then Ricketts, retired and has passed away. But Patty, there were other technicians before that. Sandy was our main one for 30 years. And then Patty was there at the same time, took over. But
Could I ask you, is there a website? Because it seems like that might be, if there's an at, that might be an email.
well, bioprogressive.org.
Okay, that's it. So
Let's
bioprogressive.org.
see if that takes you to something.
Try that.
Because
Bioprogressive.
that address is the FMBO, the diagnostic services.
Yeah.
And I would tell you that there's two doctors at University of Illinois that are the guiding light for the organization and advisors and knowledgeable. But Dr. Budi Kuznoto and Dr. Flavio Sanchez are the two at Illinois orthodontists. They're brilliant guys, but they help and they're part of the company too. But Patty's an orthodontist, like I said, Dr. Dutton.
Is this it right here? Foundation of Modern
Yeah,
Bioprogressive.
that's it. Yep.
Okay, so everybody, this is bioprogressive.org.
But if you're there, you probably have data services or analytics or diagnostic services.
It says introduction, seminar, events, download, publications, FMBODS.
There you go.
That one. Yeah. Tracing sheets,
There you go.
metric description, visual norms, growth.
Visual arms, I just mentioned those. It's fabulous. But
Okay.
I think for starters, just reach out to Patty or to that address and then Patty will respond and then that puts you in touch. So I
Okay.
thank the acupuncturist for having interest.
Yeah. He's a very cool acupuncturist.
Yeah, sounds like it.
I loved having him. Okay, last question. Wait a minute. No, two more questions. Can you get? Yeah, no, well, last question. This is Carly Merrill. Hopped in late, but would love to hear the whole webinar. Good. You'll be able to. I'm a manual therapist, a manual PT trained in MLD, buccal massage, and very fascinated by improving cranial, facial, and airway alignment for optimal core activation, movement efficiency, and how we can stack pelvic floor, diaphragm, jaw, and integrate the three. Would love to keep listening, but need to put kids down to bed.
Yeah.
Okay, so
So do you. You got to cook dinner for those kids.
so it sounds like she's kind of in this field, but wants to learn more.
Yeah, I love it.
And I think that this is a great place to first of all, I wanted to share just a couple things.
And Jenny, would you not say that all physical therapists are manual therapists?
No, not all of them, unfortunately.
Okay.
Some schools do not go into touching, and it's more exercise
Wow.
based. It's
Wow.
So
Is
I
that
studied in
American
Holland.
schools or elsewhere?
The Dutch where I studied were all like you just start touching right away and
Yeah,
like you
yeah.
feeling. But there's some schools that are not hands on. So
But
it's
in America, I mean, they're American
in
schools?
America, yeah.
Wow.
Yeah.
Okay.
Okay, so I wanted to just share this is something we learned at my course, this nasal valve support. They're little kind of like a little nasal appliance to keep your nasal valve open. And one of the therapists was wearing one during the day because he has a nasal collapse problem.
Is that a
Uh,
little pillow device inside, or is it
you
extra?
put it inside.
Yeah.
I ordered some. I got to measure myself. You got to do your own measurements, but I'm going to start doing that this weekend to get these customized to my nose to see
Yeah,
if
yeah.
that was one thing I wanted to share. It's called Nasal Valve Support, and it's a small company, and the man's been doing it for many years, I think out in California.
Is
But
that
that's,
the website, nasal valve support? Is
yep,
that,
Nasal Valve Support. If you Google that, you will find them. They're not cheap, but I think total it was $745 for both. Um, but I wanted to share, like for that therapist that wants to learn more, I would say this is the course. This is a good course. It's the only course in PT that's really focused in bringing you to a place where you can actually use all after the weekend, you can really train anybody. And the majority of people that I know have some kind of breathing or airway problem. So a lot of people are clenching, a lot of people are snoring, and this is more the functional part of what Dr. Grummons is talking about. Like we work together as a team. I deal with the majority of my referrals are dentists, orthodontists, people that are wanting the support around the structure. So they might be creating the structure, but you're going to learn how to create the function of the nose, how to get the nose to work, how to get the throat to be stabilized with the back of the throat and the tongue and the uplock maneuver and training that uplock, measuring that suction, having those objective measurements. I go through capnometer training where you are measuring CO2 levels, which we haven't talked about that at all, but CO2 for me, it tells me a lot on how to approach the patient and how to deal with over breathing and mouth breathing. The majority of the people that we treat are either mouth breathing or breathing too high and too shallow. So we teach you how to work the rib cage, how to get the rib cage to move, how to get the rib cage to lower, right? If you have a rib cage that's up next to your ears, your neck is going to be active all the time. It's going to create a lot of change in your cervical spine, change in your thoracic spine. So we need to work together as a team. PTs need to be a part of this. Anybody that treats with their hands that can touch really should understand what happens when you breathe through your mouth improperly for years. What is the skeletal changes? What are the musculoskeletal changes? What are the neurological changes? So we'll go through cranial nerve integration, we'll go through rib cage mobility, we'll go through up block maneuver, we'll go through good oral posture exercises to get your mouth in a good position. And we'll get you doing exercises that actually mobilize and move your rib cage. So if anyone's interested, this is the QR code. I teach in Chicago, in LA, in DC area, and also I am open to host, you hosting a course and having me come and teach your group, or hosting a course in your area. So that's that. And the
Jenny, can I throw one thing in? I heard you
yeah.
mention the CO2. I'm hugely interested in that. And when I was in dental school, I trained as an inhalation therapist, which was before respiratory therapy. So that's what we were called. So I trained to work a hospital job at a heart hospital, but I learned a lot from that. But it was the CO2 thing is so important. We all think oxygen, but I
We
want
don't
to give a reference of Roger Price. So anybody listening, go online to Roger Price. He's in Australia again. He's gone back home, but he's written so much and emphasizes this. But Roger is brilliant. and as a physiologist, just really makes this understandable for us. So go online and just Google him and read his stuff.
Yeah, I've trained with Roger, and I think he's also a wonderful man and
Yeah, he is. He
a
just is.
character. He's a character.
But we talked about
So
breathing.
knowledgeable, like he knows this inside and out.
Yeah,
Um,
better than any of us. But breathing disordered sleep, because a breathing problem precedes the sleep problem. And
Absolutely.
we're all talking about sleep disordered breathing. No, we think of it breathing disordered sleep. It's
Right.
not what it's called, but that's how we treat them, and that's what
It's a
we do.
day and a nighttime problem. It's an all day
Yeah,
problem.
yeah.
So, and I have, let me think. Oh, I think I'm stuck
We
here.
should do a podcast together. We agree on all this.
So, you know what? There's one last
Thank you
thing.
for the attendees. We appreciate your support.
Yes, yes. And just one last thing, if anybody's interested in learning more about the Rockabato approach, I'm teaching a course in Chicago, November 14th and 15th. There's a QR code here that can guide you to the AAPMD site. They're hosting the course. So I am excited to say we're going to have number two, podcast part number two with Dr. Grummons, all around TMJ pain and posture, unraveling TMJ through the collaborative care with Dr. Duane Grummons. So that's November 18th. Look out for your the registration for that. This has been very informative, lots of fun. Thank you for your time, and all that energy you put on that presentation was fantastic. So Duane, thank you so much.
Yep.
You in November.
Yep. I'll be there. See you at the top.
I see you at the top. I love it.
Okay.
All right. Goodbye, everyone. See you next time. Thank you so much.
Bye-bye.
Thank you for listening to the Breathing Lab with Dr. Jenny.